Good afternoon, everyone, dear chair, dear audience. My name is Galdzytska, and I would like to share with you my progress at this complex exam about my thesis, the role of the chronic systemic inflammation in cardiovascular pathology. I am a PhD student and also a clinician, and together with my team, we had a vision when we started this project to improve approaches to the diagnosis and treatment of patients with chronic systemic inflammation. For those, we have two specific goals. First one, both of them we started in autumn 2023. And the first my project is investigating the role of inflammatory biomarkers on the development of adverse cardiovascular outcomes in patients with coronary artery disease. So inflammation has been proven as a very important and playing a huge role in the atherosclerosis in cardiovascular pathology. We have very big variety of inflammatory biomarkers that play the role. So they are actually mediators and also different cell effectors, different acute phase proteins, etc. But biomarkers evaluation has not been implemented in the routine clinical practice. Therefore, we have no actually proven evidences about how we can use it for the risk assessment of our patients. I'm sorry about these formatting problems. I hope you can read my slides. So the aim of this project was to use the inflammatory biomarkers in the risk assessment. So our clinical question was, do inflammatory biomarkers play a role? And for that, we use the PFO framework, where we have two subgroups of the population, patients with chronic coronary artery disease and with acute coronary artery disease. Inflammatory biomarkers were the factor of interest, and we have the outcome. Primary, it was the MACE, but also we have the mortality as additional secondary one. Our hypothesis was that the patient with elevated levels of inflammatory biomarkers have higher risk of these events. We conducted a systematic search in November 2023 with these two domain-included search key. The first one represented different biomarkers that were based on the preliminary research that were playing role and were theoretically or somehow clinically proved in the cardiovascular pathology, and the second domain representing the coronary artery disease itself. So we started with more than 40,000 articles, and we included 631 eligible texts. From those we have 281 for meta-analysis. So I would like to share with you some of my results. The first figure is showing the association of cystatin C and MACE in the patient with acute coronary disease. I showed here only multivariable analysis. They are more robust, let's say, about the results, but we also have univariable analysis in all these figures that I will show you now recently. I will show you. The univariable analysis shows the effect as well. Except one, I will tell about it a little bit later. So at this figure, we see the cystatin C. Cystatin C is a marker that nowadays usually proved as a biomarker for the kidney disease. However, it's produced by all nucleotide cells and also by the cardiomyocytes itself. So it's increasing the inflammatory, so playing a role in the inflammatory process, in the remodeling of the myocardial tissue, so on. So as you see here, the overall effect is 1.26 hazard ratio that seems that patient with increasing level of the cystatin C has 26 higher risk of development of the MACE. The heterogeneity, let's say, moderate in our case, and the risk of bias assessment for the including papers were also, let's say, quite moderate quality. Usually, that's the most important problem with those articles was the absence of the predefined protocol. If we're talking about the chronic coronary disease and this biomarker, we also reach the statistical significance, also the clinical significance, also have increasing risk of patients who have the increasing level of this biomarker for the MACE prediction. Figure 3 shows us the adiponectin and MACE association in acute coronary disease. So adiponectin seems to be the protective anti-inflammatory biomarker. It's usually produced by our fat tissue and influence on the mainly on the coronary artery pathology through the correction of the metabolism. It's increased the sensitivity to insulin. So in patients with acute coronary disease, if you're talking about this acute phase, usually we will see increasing level of adiponectin. And as you see, it shows a moderate effect also on the MACE prediction, 13% increasing. If you're talking about chronic coronary disease, we will see absence of this effect. Again, it might be because this adiponectin has a protective role, so we've seen through the theoretical investigation through different literature that in patients with coronary artery disease, adiponectin level actually drops down, so it's actually decreasing, so have no this protective effect anymore. Figure 5, talking about the association of NT-proBNP and MACE in patients with acute coronary disease. It's quite interesting because we were looking mostly on the patient without heart failure, and we know that NT-proBNP is a marker for the heart failure patients, mainly due to its releasing as a result of the stretching of the myocardial tissue. So here we also see increasing risk of the MACE for the patient with this biomarker elevation. And for chronic coronary disease as well, we see almost half of increasing risk. My last figure for today is about the interleukin-6. Interleukin-6 is, again, a well-known biomarker, and it's not only biomarker but also a mediator. It's actively involved in the inflammatory process in cardiovascular pathology. It increases also the releasing of the CRP, so through the different mechanisms. And in this case, we have only chronic coronary disease analysis because for the acute coronary disease, we have only univariable analysis, and unfortunately, it haven't reached the statistical and clinical significance in this regard. That could be because when I was screening the articles, mainly they were including patients naive to coronary artery disease, so the infarct myocardial acute coronary condition was their primary manifestation of the disease. So it could be that longer interleukin-6 is present in the bloodstream, more strongly it's connected with the MACE. It was the hypothesis. So if I would like to summarize our findings, we were exploring more than 200 biomarkers. Unfortunately, for 150 there were not enough data, so less than 3 reports were talking about these biomarkers. We had the qualitative summary for those. We find out the association in more than 15 biomarkers, and also the borderline effect were found. So it means that the statistical significance wasn't reached, but it was very close to it, so more than 0.9, the lower confidence interval. And I might highlight that it could be because of the not enough data, because usually these biomarkers were analyzed in from 3 to 5 reports only, and we also observed no association in some of the biomarkers. As a conclusion, I would say that in our study, we find that interleukin-6, CRP, cystatin C, growth differential factor 15, and NT-proBNP might be useful for assessing MACE and or mortality risk in patients with coronary artery disease, both acute and chronic. As implication for practice, we would consider the usefulness of these biomarkers in routine. And as an implication for research, of course, the standardized cutoffs and prospective studies are needed, crucially needed, because this is a promising topic, I think, and tracking biomarkers changes over time may improve risk prediction. We have, again, strengths, limitations. So the strengths this is one of the most, I would say, to the best of my knowledge, the most comprehensive analysis and review around 200 biomarkers. We could reach the large sample sizes of the real-world population from more than 38 countries. We could separate the acute and chronic conditions that can lead to different results. And of course, both univariable and multivariable analysis were available. As a limitation, I would highlight the observational study or secondary analysis of the RCT mainly were included, and they were not predefined for the biomarkers investigation. The high heterogeneity, not pre-specified or data-driven cutoffs in most of the studies, and of course potential reporting bias that we couldn't avoid for 100%. This is the status of my manuscript. It was submitted just recently. A few words about my second project that will investigate the role of inflammatory biomarkers in the development of in-stent restenosis in patients underwent percutaneous coronary intervention. Again, we know that inflammation plays a role in all processes in our body, and as PSI is quite often it's kind of the gold standard for the treatment of patients with acute coronary syndrome. It's still has quite high level of the in-stent restenosis, and we would like to address this issue by, again, assessing the different biomarkers. The clinical question, as you see, inflammatory biomarkers and their role in this in-stent restenosis. We have a similar framework where patients underwent PCI will be investigated under the influence of certain inflammatory biomarkers, and we have in-stent restenosis as a primary outcome. The hypothesis is the patient with elevated level have higher risk of this in-stent restenosis. That might be very important in future clinical practice, that it can potentially improve the monitoring of such patients, and of course give highlights about the new treatment strategies. So in summary, I have 2 ongoing projects, and I would like to finish my presentation by my favorite words: keep your eyes on the stars and your feet on the ground. Thank you very much.
Thank you for your presentation. And again, first of all, the questions from the audience. Do you have any questions somewhere?
Somewhere.
Well, if not, do you see any question? No. My question would be, and I have to tell you that I am absolutely not into cardiology, so I'm not experienced. But do we use any of these factors that you mentioned, these 5 screening methods, or is it in clinical use or not? Still not?
Unfortunately, no.
No.
And there were some risk scores that include the CRP as a potential marker for the cardiovascular events assessment. However, it's still discutable, and the European Society of Cardiologists, they have no clear evidences regarding this. Yes, so this is an open question. So everyone knows, and this is one of the highlighted gaps in the literature by ESK 2021 guideline, that we need to address it, but not yet.
And so you mentioned you examined, let's say, 200 biomarkers, and these 5 were the most promising ones, or?
Yes. So these 5, as unfortunately I can't recommend it with high confidence, because we have again a limitation as only observational studies that did not give high level of evidence. Therefore, we were quite modest and critical to our results. So that's were 5 that are the most promising because they have the hugest sample size, let's say.
And could you use it? Could you use them independently or as part of a risk score or something like this?
So we were investigating them independently.
Thank you so much.
So congratulations for this huge work. I'm just asking, would you mind if I passed the mic to you first, and till I will just pondering a bit more on my question, because I have several ones. And yeah, so okay. Thank you.
Then I take it over, and congrats. This was a tremendous amount of work. My question would be, from these 5 biomarkers, the NT-proBNP is included in the preoperative risk assessment. for cardiovascular risk, and if it's high, it's correlated with a much higher cardiovascular risk in the perioperative period. And it's suggested that you should optimize the hemodynamics of the patient preoperatively to avoid this, but the main problem is, how would you define the normal pro-BNP level? What do you call elevated?
Yes, thank you very much. That also was one of the limitations, that we assume that in most of cases the cutoffs were data-driven, so they was just divided. So there are two options how the investigators and researchers act. First of all, they have just cut off in the middle of the, let's say, observed level of the biomarker, and another they just have the tertials or quartiles. And in our study, we were, or rather taking the cutoff or using the highest versus lowest, how they defined it. Yeah, so it's indeed a hugest limitation of our study.
It's a very difficult question because pro-BNP is age-related. So the normal range is totally different for an elderly than for a younger one. It's twice as high for an elderly. So that's that. Did they elaborate on this problem in the studies, or did they just take one cutoff and that was all?
Yes, usually they just take the cutoff, and that's all. The maximum that they do is there were no stratification based on the age. They do the adjustment for the age, but of course we think it's also not enough. Yeah, so that will lead to recommendation in further studies. We need to stratify the age. We need to stratify the follow-up periods, because it seems that for many biomarkers the effect change within the time, especially in chronic coronary diseases. For example, I don't know, I even find when I was reading the articles eligible for that study that I think for interleukin-10, their researchers observed that after 4 years, the significant were lost completely. Mm-hmm. And they will follow up to 6 years. So it's something that might be considered when you are writing and define the protocol of the investigation, I think.
Yeah, thank you for the explanation. Thanks.
So, congratulations, huge work. Maybe it's a naive question, but how specific are these, because you looked at a lot of biomarkers, how specific are they for coronary disease, and were the adjustments made for other inflammatory conditions that could have influenced the levels? And I think you already answered that. How much time do we have between finding an elevated level of the biomarker and the event actually happening, and how should we address finding this elevated biomarker? How can we prevent, or what should we do?
Yes, thank you very much for this question, because it's highly related to the primary and my additional idea why I actually started this exact project. Because when I started my work as a clinician, and I'm a rheumatologist and a general practitioner, I was shocked that everyone knows that inflammation influences certain outcomes, including cardiovascular pathology outcomes. However, no one knows how exactly and what to do and which biomarkers we should look. And everyone, like every rheumatologist, have like a packages of the inflammatory biomarkers and different markers and mediators and so on. So how to do with all of this? It was my primary question. Yes, regarding the second project, let's say, what to do. We have different follow-up periods, and one of the reasons why some of the studies on the figures show very wide confidence interval is because they have shorter or much longer follow-up periods, of course, by taking into consideration the event number. I would say, again, we need more pre-specified studies that demonstrate different rates of the MACE at different time points that were exactly examined at specific time points. In our study, we haven't any limitations, so we include, because we use the hazard ratios that, let's say, proportionally show us their true effect within different time points. So we include studies from the shortest was half of a year, roughly. In some studies, we have just in hospital, so it's around 30 days, let's say, or 1 day, or during the rehabilitation period. But mainly it's half of a year, up to 10 years, and even more. Yeah, so it's very different. It's varied, and also it's increased the heterogeneity. We know it. What to do? It's, of course, we have. So initially, to a little bit narrow my project, we were interested only on the risk assessment, not about the management of such patients, because it's another huge, let's say, work. But we know that nowadays we have many trials that trying to target with the biological therapy exact specific markers. Interleukin, for example, 1, 6, 17, 6 receptor, interleukin 1 beta, and so on and so on. And actually, some of them on the final stage of the investment, and plus I know that interleukin 1 inhibitor have already recommended in the USA for the treatment only for pericarditis, but it's cardiovascular pathology that is a huge win, I guess, as a secondary line therapy, but still. Yes, so that in general. Sorry, the first part of your question. Sorry.
Yeah, so I was wondering how specific they are, but you already touched upon it. That
yeah, they are not actually very specific because, like cystatin C, for example, is produced by all cells that have nucleus. So yes, it's a good and bad at the same time, because we can potentially extrapolate these findings on the risk assessment of MACE for patients who not just have cardiovascular pathology potential, but it's again some additional studies comparing this different population. In our study, we're trying to avoid inflammatory diseases. The only ones we exclude at the full text selection stage, everyone who, every studies that have inflammatory disease, except diabetes type 2, because unfortunately they're very hard to have enough studies that include the population without diabetes type 2. Yes, so that's the only one. Yes, I would say. Thank you.
So congratulations again. So you have been working on this huge project for like 2 years.
Yes.
So yeah, I have just read this small summary of your work, and I could see that, and I realized that you addressed your main questions from a different perspectives rather than cardiology. It's more like from the perspective of chronic inflammation and the potential role of chronic inflammation in major cardiovascular events. But rather, I was just pondering, and that's why I asked you to ask first, because you know, I'm a nephrologist, so I can tell you that I'm just starting thinking about that. This huge work may contain a lot of very, very interesting results regarding the future cardiovascular disease prediction, which can be like very important to the prediction models. But anyway. If I want to generalize the results of your work, my first question would be whether you divided the patient population according to CKD stages and the type of CKD, because you know that like the major cause of mortality in chronic kidney disease is like cardiovascular disease, which means that CKD is one of the major cause of major cardiovascular events as well. So if you do not exclude end-stage kidney disease patients from the population, then it could result a bias, a selection bias, which can like make a bit difficult, the generalizability of the data. So my question would be relate to the inclusion and exclusion criteria. So how did you choose the patient population? And the second one is that it connects to the BNP, because you know that pro-BNP is also correlate with creatinine and cystatin C level. So that is also not only age, but creatinine can also influence the level of BNP. So could you just comment on those two parts? Thank you.
Yes, thank you very much for your comment. It's very valuable. We're also trying to address that. So if the patient's baseline characteristics include separate results for the patient of different kidney disease, we include only those that have normal level of the filtration rate, so without severe nephrological pathology. Yes, we exclude those that
EGFR lower than 60 or lower than 60?
Even 90 in most.
Lower than 90?
Yes.
So then it's a homogeneous population.
Yes, but so then, I must consider that not in all cases, not in all reports they telling about that. So we assume that, of course, if this severe pathology or exists among the population that they include, they might report it. However, we should tell the truth that not in all cases it was a part of the baseline characteristic of the patient.
Have you included those studies which did not report on that?
Yes. And in our discussion, we were telling about this as potential limitation, mainly in the part about the cystatin level. Yes, but yes, we addressed that. So where it was possible, where it's clearly reported, we trying to follow the most strict inclusion criteria. However, not in all cases it was reported. This is about the quality of reports mainly.
Okay, thank you. Yes, and what about the BNP? Have you comment on BNP as well, or I just need that? Kidney disease and BNP.
Yeah, so everywhere. So actually, it was the routine.
So this is the answer to that question.
To all biomarkers actually. So we were trying to exclude all severe pathology except acute coronary syndrome or severe cardiovascular pathology except type 2 diabetes, and also heart failure sometimes were present in some percentage, different percentage, but we're also trying to address it in the discussion.
And which marker would you use as a surplus or an additional marker to the score, for example?
I would use all of them because all of them seems to be promising, but I would say there are not enough data still, not enough evidence, not enough strong evidence to change completely the management. So it's recommended, but not strictly
thank you.
With our level of study.
Thank you for the presentation. For one, I have a comment. I've already mentioned in the previous section. It's rather a general comment for many of the projects in the CTM, the alpha inflation related to the vast amount of outcomes examined in many of the articles or topics. So it needs to be taken into account that if you make many comparisons, you will inevitably find erroneous results, and erroneous. You will discuss those results. So if you have a large amount of outcomes, you have to be very cautious with your results. My first clear question is that you mentioned many times that you had multivariate and univariate HRs as well. Were there cases where you've seen effect modification, so where the univariate and the multivariate HRs showed basically completely different things?
No.
So most of the cases
most of the cases, yes, are quite consistent. So if the biomarkers show the multivariable, let's say, significance, that means that probably in univariate that also shows significance. If they both have failed to reach something mathematically, they both. Yes, so.
Okay, my next question is that I just noticed that in your grade assessment, domain 7 was always yellow.
Yes.
So why is that? I just noticed that the grade was everything was downgraded because of domain 7.
Yes, and I briefly told it. It's the last domain. It's about the. So the main reason was the absence of the protocol, predefined protocol. So it's the main, let's say, bias in our opinion.